Okay, welcome back. Welcome back, everyone. If you have the sign-in sheet at your table, will you pass it around? Make sure everybody kind of sees where it is, and everybody sign in for this morning. Okay, our next session focuses on a topic that touches every one of us: the state of mental health in Oklahoma. Are we ready? Everybody ready? All right, this discussion will explore the progress that we've made, the challenges that we continue to face, and the strategies being implemented to improve mental health care across the state. It is my pleasure to introduce Mr. Zach Stoikoff, the founding executive director of Healthy Minds Initiative. Under his leadership, Healthy Minds has become a leading voice for mental health reform in Oklahoma, helping design and advocate for policies that have expanded access to care, strengthening funding, and improved coordination across systems. Zach and his team of public health and policy experts advise state and local leaders on evidence-based solutions that address workforce shortages, youth mental health, and parity in insurance coverage. His collaborations have brought millions in new resources to Oklahoma's behavioral health system and helped pass some of the nation's strongest mental health legislation. He previously served as Vice President of Government Affairs for the Tulsa Regional Chamber and worked in journalism covering state and local government for the Tulsa World. Zach holds a master's degree in public administration from the University of Oklahoma and brings more than 15 years of experience shaping state policy. Please join me in welcoming Mr. Zach Stoikoff. Thank you. Good to see you.
Well, hello, everybody. I'm going to try to be a little bit more mobile than right behind the podium, so this works. How's this? All right. Well, good afternoon, good morning, whatever it is. I don't know how I feel about going after the awards, but maybe that's a good thing. I'm here to talk to you about the state of mental health and kind of some of the challenges, but also the opportunities in front of us in Oklahoma, and hopefully add some time for questions at the end. I like to show this map kind of before I start presenting on this topic, and I'm curious if anybody has a guess as to what this map represents. Oh, I heard Oklahoma. Is it Gold Star? Any other guesses? Each dot on this map represents nearly 8,000 Oklahoma lives lost by suicide in the last 10 years. That's about 2 lives a day for 10 years, and it's getting worse. So who is Healthy Minds Policy Initiative? We are the state's think tank for mental health and behavioral health systems change. We are trying to transform outcomes in Oklahoma, but we do so not by necessarily being activists, but by supporting our leaders and our policymakers, both at the state level and the local level, in developing solutions for these problems. We also support systems and providers in developing solutions. We're evaluating how we're doing in the state, constantly putting out research, constantly convening groups, frankly, like this one, around some goals that are very practical about how we start to address some of the gaps that are identified in the research. And then, as former Representative Randleman knows, we draft legislation, we help legislators kind of make a difference in this issue. So we've done a number of those bills in the last 6 or so years of our existence. We believe that mental health can be a catalyst for a better Oklahoma. What does that mean? We don't think mental health needs to be something that holds us back. We think mental health can and does propel us forward in workforce and economic success, in education, and all these other issues. So I also like to say I'm not really a mental health think tank at Healthy Minds. We're an education think tank. We're a criminal justice think tank. We're a healthcare think tank, because mental health does play a role in each of those things, as we all know. So some of the challenges that we're facing in Oklahoma right now. We can talk about the percentage of people who have a mental health condition or a substance use condition, and I almost sort of want to breeze past that because the data and the numbers that really concern me are those who have a need and don't get that need met. So for a larger mental health, any mental illness, we're talking here about 53% of Oklahomans who have a need do not get that need met. But when we talk about substance use, it's about 3/4 of Oklahomans who have a need for treatment do not receive treatment. So Healthy Minds is about trying to figure out why that gap exists. Need, not receiving treatment, why is that the case? We'll talk a little bit about that. I will go over some data here. Just, this is a room full of psychologists. Nothing here is going to surprise you, hopefully. But let's go over some of the current numbers that we have. So Oklahoma's suicide rate is bad and it's getting worse. We're the 9th highest suicide rate in the country. Suicide is a top 10 cause of death in Oklahoma. You can see that blue line represents suicide. It's nearly 3 times higher than our state's homicide rate, which surprises some folks when you're not involved or aware of what's going on with the mental health crisis. That green scary line is unintentional drug overdose. It's approaching 4 times higher than our homicide rate. And it's been going up in recent years. There's some recent data that says maybe nationwide and maybe even in Oklahoma starting to tick down as Narcan is kind of come into the picture in a big way, but still a major issue. So suicide in the last 10 years has been certainly trending up nationwide, but it's been trending up even higher in Oklahoma. So it's getting worse relative to the national average, which is what we really need to talk about when we talk about what are we doing and how are we doing in Oklahoma. If we're getting worse in the nation as a whole, we know there's something that we could be doing. It's a little bit different. I'm talking about the drug epidemic. We're really in the 4th wave of the opioid crisis. It started, of course, with prescription opioids, and that's what kind of got all the settlement dollars flowing from the national distributors and manufacturers of opioids. But really what we're talking about now is really a methamphetamine and a fentanyl crisis, and then now really novel substances, horse tranquilizer. We've talked about, you Google gas station heroin. I mean, these are kind of things that we're dealing with now, but really methamphetamine and fentanyl together causing a massive increase in overdoses. And these are the overdose numbers in the state. You can see generally by substance here, all unintentional overdoses. These are, of course, fatal overdoses, that black line at the top. But then look down at methamphetamine is still the highest. If you combine every opioid, it's about the same now. It's a little bit under. Fentanyl, just a little bit under that. But what this chart doesn't tell you is the commingling of these substances, which is increasingly an issue. Every single county in Oklahoma has high overdose rates. I mean, this is not something that is urban, rural. This is something that's happening all over the state. And it's driving a lot of problems, both for the criminal justice system, the education system, and the healthcare system. So this is also our, I think, important data to think about when we think about what is the need in the state, because the fatal overdoses are actually a pretty small percentage of the overall overdoses. And overall overdoses, let's look at those numbers. Total unintentional overdose rate, 32.7 per 100,000. Statewide, this blue line, all drug overdoses, 109 per 100,000. So you can see the relative scale there. And on the right side of this chart, you see opioids. So we've got a big problem in the state. We've also got a big youth mental health problem, as those of you know who deal with children, youth, and families. A couple of Surgeon Generals ago, it was declared that the youth mental health crisis was going to be the lasting impact from the COVID-19 pandemic. We have seen exponentially higher numbers, but really not anything new. These numbers had been going up for years. What happened during the COVID-19 crisis was we really showed the weaknesses of our system in addressing this, right? So we saw a lot higher numbers of children going into the ER with suicidal thoughts or other kind of mental health issues than we did prior to that. But that doesn't mean, what that tells us is that our system wasn't capable of meeting the capacity we need, right? But what we see is that there's been actually some improvement here. These are statewide numbers from actual assessments conducted anonymously in classrooms of students across the state. They're still scary numbers. So let's look at 2017. Considering attempted suicide, almost 17% of our students said that they considered attempting suicide, and 9.3% said that they had attempted suicide at some point. These numbers are trickling down a little bit, down to 14.3 for considering, and almost 7, down to 7 for attempting, but certainly not a number that any one of us would be proud of. But what we do see is there's some moderation happening post-pandemic, as the world is kind of, for a number of years now, has returned to somewhat normalcy. So let's talk about I mean, we can talk about this all day. I'm not going to bore you with the root causes of the problem, but let's talk a little bit about the root causes. You're all psychologists and you would understand this slide, of course. What causes mental illness? When I talk to other groups, I don't have to really say this to this group. Mental illness is a disease that is treatable. It is not a personality flaw. We do talk about that, but we all know that mental illness is a disease of the young. So we know that where you grow up matters. We know that the majority of mental illness sets on by adolescence. We know that there is a genetic predisposition to mental illness, like there's a genetic predisposition to cancer, right? But if you smoke, you're more likely to get cancer than if you don't smoke. Now, someone who's a non-smoker may get cancer quicker or more often than somebody who's a smoker because of genetic predisposition. But what we're talking about here is that there are a lot of other layers on top of that. This is what we can affect, right? So we can talk about relationships. We can talk about your family structure. We can talk about organizational ability to address those needs that you might have. So say you did have a high trauma background. Well, we hope that your school has universal prevention supports because that's going to help mitigate that effect of that high trauma background, right? We can go all the way up to society here and talk about stigma. Help-seeking stigma is a big deal with substance use disorder. Most people who don't seek treatment actually don't seek treatment with substance use disorder because they are afraid what it would say to their friends and family who see them getting treatment, so they're going to choose to stay sick. I mean, that's a real factor in these conversations. Policy is a big deal when you see any map of counties in America, the darker shaded counties, and you see Oklahoma's brightly outlined. Well, policy. Here's an example of public health policy that has really been successful in this country. Seatbelts actually reduced deaths from traffic accidents, right? When we stopped tobacco companies from advertising to youth, we saw rates go down, right? So policy can make an impact, and we think that it can in mental health as well. One of the things that we really like to talk about at Healthy Minds, people think that we are a legislative think tank, and while that is true, we actually work probably even more with communities than we do with the legislature. So we are diving deep in neighborhoods and working with local officials and figuring out what are those factors that both promote mental illness and mitigate the risk for mental illness and substance use disorder. One of the ways that we do that is we look at the social vulnerability of neighborhoods in a community. So this is a map of Oklahoma County and Oklahoma City. And what we're seeing here is we're using the Social Vulnerability Index, which is a CDC measure derived from the American Community Survey, which is an interim between US censuses. And it generally categorizes 4 distinct risk factors for social vulnerability. Your housing status. Is it a crowded house? You got a lot of people in there. Do you have a car to transport? Are you part of a racial or ethnic group that has a higher propensity to mental illness or is underserved historically? Are you, older? And are you a senior citizen? Are you young? Different things that taken as a whole, maybe not as one individual makes you more at risk, but a population level perspective, it makes a population more at risk for higher instances of conditions. So together, these 4 measures, social vulnerability, is actually 16 measures underneath these 4 categories, but I won't bore you with that. Here's what I'm going to tell you is these red shaded zip codes are the highest need in Oklahoma City. What we're going to see is that those zip codes are most vulnerable to disasters because municipal officials use this data to prepare for emergencies and disasters, but more vulnerable to public health emergencies and mental health conditions. Mental health prevalence generally tracks with the social vulnerability index because these are neighborhoods where you're growing up in an area with high trauma or you're more likely to develop a mental illness. In Tulsa County, since that's where we are we in Wagner County right now? We're close enough. Here's Tulsa County. Those red areas, generally North Broken Arrow, which is where we are now, not South Broken Arrow, but North Broken Arrow is a higher risk. Over to Sand Springs, North Tulsa, you can see those red zip codes. This is going to come and play in a minute because I'm going to tell you some slides about how we're dealing with these zip codes and the mismatch of resources, but that's one of the things that Healthy Minds wants to look at. So when we look at a community or a state or a region, we talk about these risk factors, we also want to talk about the tools that we have available to address them. And so this is one way to look at an evidence-based mental health continuum of care. Healthy Minds didn't make this up, but I think I've never seen it depicted as a pinwheel like we depict it. It's often like a line graph or something. But here's a pinwheel of the mental health continuum of care, okay? What we're saying here is that we need a baseline for any population of universal promotion, there's awareness of mental health issues and how to deal with them, and prevention. And then what we need to do is we need to get ahead of these conditions. So if you were really going to look at this and sort of right size each of these colors according to what they should be, you would see this early integrated care and early intervention one, like 60% of this pinwheel, because that's where we can catch and address mental illness early in primary care settings and whatnot. That's not how we allocate our resources. It's going to be much more loaded towards the end of this. Is how we actually do it. We put our resources at the fire, right? So most of our resources are going to jail and inpatient, and higher levels of care, right? But there's some gaps here in the middle we're talking about in a minute. When we're looking at a community, we want to make sure that each of these is right-sized, and we're going to develop recommendations for resourcing so that our needs are met before it becomes a fire, right? And so that's what we're talking about with this continuum of care. When we talk about the continuum of care and how we use the tools, we need to talk about how we pay for the tools. Probably first and foremost, it's the second word, it's out of our breath. And here's how we pay for healthcare in Oklahoma, right? Actually, about half of Oklahomans have commercial private insurance. And that's a big deal because in public health, we often focus on Medicaid, but half of our population has commercial. And with behavioral health, this is not an issue that is limited to people who are eligible for Medicaid. It's certainly every income strata. So we have to talk about that, and we will in a moment. Then we talk about Medicaid. Medicaid is about 22% of the state, Medicare about 15% of the state. We also have the second highest uninsured rate in the country, people who have no insurance. What do we do about that? So we talk about that. Difference between Medicaid and commercial insurance. Does anyone here take both? Thank you for taking Medicaid, by the way, I appreciate it. Medicaid, in theory, covers more of that pinwheel than commercial insurance. Commercial insurance almost always only covers outpatient care and maybe a little bit of inpatient care. There are multidisciplinary teams as part of these intensive services. There are wraparound services that are a part of those evidence-based practices, and most of the time commercial insurance does not cover those. And it's a terrible disaster because it's impacting our ability to get you well before you hit the most expensive levels of care, inpatient or, God forbid, jail and death. Commercial plans largely don't cover those, but they do largely pay for outpatient care a little bit more than Medicaid. But what we're seeing is that there's a big difference when you're talking about an Oklahoman trying to get care, whether you have Medicaid or whether you have commercial insurance. There's a big difference in provider availability. Medicaid provider roles have been shrinking drastically under managed care. Providers are leaping off that ship. I saw latest monthly numbers from this. They're actually down even more, I think down 10 to 20% in the last 6 months in terms of behavioral health providers and services being accessed on those plans. So this is a big, big, big problem in Oklahoma. But commercial plans, we also see a lot of limited availability for providers who are largely now taking just self-pay. So guess what? For a policy entity that's worried about are Oklahomans getting care, we are extremely worried about whether Oklahomans are getting care because there's fewer providers taking Medicaid. There's fewer providers even taking commercial plans. So you have to pay out of pocket now, largely for health care. That's not just true of behavioral health, but it is true of behavioral health. One of our key safety net issues in Oklahoma are certified community behavioral health clinics. This is an evolution of the community mental health model. CCBHCs are extremely important in the state because it's how we generally provide that full spectrum of pinwheel services that I mentioned earlier. So those multidisciplinary teams, more intensive services than just your typical outpatient therapy session. A lot of people do need that level of care. CCBHCs were designed to cover that, and they were designed to cover that in a payment model that is paying them monthly for somebody's ability to stay well. Again, in theory, and I'm going to stress that in a minute because there's some things we need to do to address this. But in theory, this is our solution as a country to deinstitutionalization when we close the institutions, never invested in community mental health, and people start cycling in and out of hospitals and jails. CCBHCs is our attempt to actually cover that. Okay, so really promising model, whole person care, 24/7 access, responsible for communities. So CCBHCs are actually, I'll show you the map, contracted with the state to provide, basically be the fire department for behavioral health. If you have a crisis in the middle of the night, if you have a need for a PACT team, which is a multidisciplinary model, or something like that, this CCBHC is supposed to be covering your community and offering those services. That is the idea. We'll talk about that again in a minute as to how well that's happening. But different providers covering different parts of the state. There are multiple providers, multiple CCBHCs certified in Tulsa and Oklahoma counties, but generally every area of the state has one. So what tools are we missing as we start to assess this landscape of the toolboxes that we have? There are a lot of tools that we're missing. Let's talk about Tulsa. I showed you the map of our vulnerable zip codes in Tulsa. We're going to look here at where the CCBHC locations are. And there's another subset of providers, CCARC, Certified Community Addiction Recovery Clinic, substance use outpatient services and things like that, that are charged by the state to offer services to people who are indigent and don't have Medicaid coverage. And by the way, CCBHCs also are required to take you if you don't have healthcare insurance. Where are they located? You can see those shaded zip codes there in Tulsa County. They're, other than 2 exceptions, they're actually not located in the highest need zip codes in Tulsa County. So we're going to look at that and say, why not? This is really where you should be. These are the people who don't have insurance. These are the people who have complex needs. This is what you are designed to do. Why are you not there? And you know, there's attempts to offer mobile services and telehealth and things like that, of course, but this is a big deal when we're talking about, is a community's needs being met? We also look at transportation. So 15-minute drive in Tulsa, that shaded area. A lot of people are within a 15-minute drive of a CCBHC or CCARC, but if you're on a public transit trip for 30 minutes, that map shrinks significantly. So we do have to talk about access that way. So I'm going to talk about a level of this pinwheel that is historically and currently missing, and we see this in every bit of assessment and data that Healthy Minds does, whether statewide or at a specific community. It's this intensive home and community-based services. What do we mean by that? We are talking about a level of complexity and need that is currently putting people largely in jail and inpatient services, most of the time not necessarily needed that way. We don't need to put everybody in an inpatient bed. We can actually keep them healthy, out and living productively in their lives and in their communities with the right level of care. And this level of care is largely missing. Again, why? Well, insurance doesn't cover it. The state has to pay for it. And there are some state funding issues going on right now if you hadn't known that or heard of that in the news. So let's talk about children. Who needs intensive services for children? This is actually a pretty big swath of our kids. Some of the things, really, you just have to be one of these for a child to potentially qualify for this level of care. Are you frequently bullied at school? Are you frequently absent? Are you involved in the child welfare system? Are you chronically stressed? Have you had are your parents incarcerated? Are you engaging in substance use? These are children who generally are not, they're struggling in school, there are behavioral issues. You're seeing this, you're seeing the effects of this in other ways, but we know there's a behavioral health condition that is the root cause. In Tulsa County, 30% of kids, I think it's probably about the same statewide, although I have this for Tulsa County, 30% of kids fall into this category. And we often call that a serious emotional disturbance. These people need more than therapy. I think that's what we need to talk about. They need more than just therapy. So what do evidence-based practices for intensive models of care look like? You will see a lot of providers, including CCBHC, say, yeah, we offer, name the EBP, multisystemic therapy, family functional therapy. Yeah, we do that. Okay, well, then you start to look at what are the practices involved in that EBP, and you start to look at what's actually happening on the ground, and you see, well, we're not actually doing that because the research that said multisystemic therapy is effective meant you actually have these components involved, and every single intensive service has these components involved, whether it's programs of assertive community treatment for adults with serious mental illness who are in and out of hospitalization, for example. They all have these models. Okay, we're talking about 24/7 on call, 24/7 response for families if you're a child. You're clearly defining eligibility and you're not fudging it, right? There's high degree of service coordination with non-behavioral health services. There's small caseloads. So I went into a provider and we started talking about one of their EBPs associated with intensive services and said, hey, what are your caseloads? Yeah, like 50. That's not an intensive service. And that's not the provider's fault. I mean, there's a resource issue here too, right? And there's a recruitment issue. So we have to have these things. And there's a number of service components so basically what I want you to point out, what I want you to come out of this is that when we're talking about whether we have EBPs in the state, there is actually a science to what these EBPs look like. And you all know this as psychologists, that Healthy Minds is very interested in ensuring that we actually have. Case in point, some data in Tulsa County, again, since we're in or near Tulsa County. We actually analyzed the Medicaid claims in Tulsa County for children. And we found that 85% of kids, who were Medicaid or state-funded mental health services were receiving psychotherapy. 63% of them were identified as having a mild or moderate disorder. If it's a mild or moderate disorder, believe it or not, it can be treated in the primary care setting. There's gaps in the primary care setting that actually don't allow that to be true currently. But in theory, it can be treated in the primary care setting. 37% were identified as having serious emotional disturbance. What we were seeing is that children in this category, serious emotional disturbance, were receiving on average 1 additional therapy visit a year than non-SED diagnoses or children who are not believed to be in this SED category. That is not appropriate level of intensity. So we wonder why in Tulsa, St. Francis almost doubled the number of children coming in the ER post-COVID-19 pandemic, actually more than doubled the number of children post 2021 compared to 2019 coming into the ER, more than doubled. Well, it's because we didn't have the intensive levels of care that you would need for children who are already extremely vulnerable. We also know there's a mismatch in beds. You know, people ask me all the time, do we have enough inpatient beds? Well, yes and no. Because if you build them, they will come, because we don't have this earlier level on the pinwheel. We don't have the intensive services. If we had the intensive services, we probably could do with the number of beds that we have right now. And it would actually be cheaper, believe it or not, than running all those inpatient beds. But we do need inpatient beds. There will always be a need for that. Let's switch to commercial insurance. Again, half the state relies on commercial insurance for their behavioral health care. This is actually a national study from the National Opinion Research Center out of University of Chicago. They asked how many people who accessed healthcare, both behavioral health and physical healthcare, how many providers did you try to engage before you actually got treatment? You can see they contacted 40% of those who got behavioral healthcare contacted 4 or more providers before getting treatment, compared to only 14% of physical healthcare seekers who contacted 4 or more. Okay, on the other side, you contacted 10 or more providers before you got treatment, 10% of behavioral health, 1% for physical health. So we're seeing there's a big difference in the number of providers who are in network with commercial plans on the behavioral health side compared to the, quote, physical health side or general healthcare side. This is Oklahoma data that shows this to be true. Oklahomans have to go out of network for acute inpatient care 5.6 times more often than they have to go out of network for acute inpatient care on the physical health side. For an outpatient office visit, it's about 50% more often they have to go out of network to find that on the behavioral health side than compared to the physical healthcare side. One reason that is the case is because the data show that behavioral health providers are paid on average 22% less in Oklahoma for similar billing codes than physical healthcare providers. Okay, 22% less for similar codes. And these were people who actually looked at the codes and said these are comparable services, there's a similar amount of effort and time by the provider, similar level of provider, or maybe a specialist on the behavioral health side who actually is more educated than the primary care physician, right? You're getting paid 22% less. Healthy Minds dove into this a little bit further. We actually conducted a couple of years ago a secret shopper analysis of the insurance plans. We looked at the 5 largest carriers in the state, and we looked at, we acted like we were a patient in 9 representative zip codes, 3 urban, 3 suburban, 3 rural, and we called the providers that were listed on those plans given to us by the networks. I will tell you the results of that in a minute, okay? So hold your breath. But we also looked at the Medicaid data. We looked at the number of certified and licensed behavioral health providers. And here are some of the things that we found. There are a few in-network substance use providers, in particular substance use specialists. This map is showing the green is within a 30-minute drive time of a substance use provider for the largest and most comprehensive statewide commercial health plan. I will keep them anonymous, but this is a statewide plan that is largely covering more providers than other plans. So 77% of the population lives within a 30-minute drive of a substance use provider. Over here, you can see that 71 to 80-something% of Oklahomans live within a 30-minute drive of a psychiatrist on this plan. 92 to 95% live within a 30-minute drive of a mental health provider listed on the plan. But are those networks accurate? This is assuming that every provider on those network directories is actually providing services. Well, we called them. Only 60% of the providers that we were able to reach, again, we were able to reach, we called them, we were able to reach them, only 60% could offer any information about wait times. 33% were able to offer an appointment within a month, and 18% could offer an appointment within a week. Okay, so that's of the providers that we called that we could reach. They're leaving out, though, the vast majority, and we're going to back up a little bit again, the vast majority of providers. So we're going to compare this large healthcare's plan to the certified and licensed providers in the state. Okay, what percentage of providers are actually on the best insurance network in Oklahoma? Health Choice is a state employee plan. Private Health Plan A is this anonymous healthcare plan that is the largest in the state. Okay, less than 30% for this largest private healthcare plan. Less than 30% of the behavioral health providers licensed and credentialed in the state of Oklahoma were on that plan in network. It was a little bit better for Health Choice, and it differs based on specialty, as you can see. But let's go back to the providers who are listed on the plan. Again, we called them. And here's what we found. We called 160 behavioral health providers in the 9 zip codes. We were able to reach 56% of them. I'm sorry, we were able to reach 56 of them, which was 35%. We were unable to reach 103% or 103 of them, which is 65%. So 65% of the providers listed on this plan were unable to be reached, including 30% of them who were disconnected phone lines. The information was inaccurate. We couldn't actually get a ring. Okay. So these are the plans that Oklahomans are relying on to get care. These are the lists of providers provided by those plans. This is a problem, folks. This is a big problem. So the networks look better than they are, and access to the networks is like we are selling Oklahomans a truck that can't run 60% of the time. Okay, that's what we're buying when we're buying an insurance plan with regards to behavioral health. That's the reality. That's the data. I'm not trying to badmouth any particular insurer. That's the data, okay? We've actually done some things to try to address this, and I'll talk about that in a minute. So let's get into those solutions. What is Healthy Minds working on as a state's think tank, collaborating with legislators and local officials on addressing some of these systemic issues? How am I doing on time? Okay. We break this down into 4 focus areas. There are so many ways to peel the onion of how to address behavioral health care, and you can hear any speaker or any of you have made kind of put it in a different way. When we're talking about it, we're putting it in 4 categories, okay? Affordable, accessible treatment. What we're really talking about is that we want it to be at least as bad as the rest of healthcare. Behavioral health must be at least as bad as the rest of healthcare. That's the solution, right? That's where we're heading. Healthcare is pretty bad, behavioral health is worse, okay? It is less accessible, it is funded less, it is treated less, it is stigmatized more compared to physical healthcare. And we see that in every bit of data that we look at. Let's talk about primary care. I mentioned that before. 63% of behavioral health conditions actually should be able to be treated in primary care settings based on the level of education that primary care physicians have. But in a study, this was a national study to be fair, but in a national study, here's what happens in primary care. 47% of cases of depression that walk in the door are detected. 24% of those, 24% of the cases of depression are treated, and 9% are treated adequately in primary care settings. So if primary care is the entry point into healthcare, I would say this is a parity issue, right? This is an issue of behavioral health is being treated less than it should be compared to physical health care. This is why 47% of people who die by suicide had seen a primary care physician in the last month of their life. Okay, let that sink in. Almost half of people who die by suicide had seen a primary care doctor in the last 30 days before they died. What are we doing? Right? We need to be resourcing testing. We need to be, I shouldn't say testing in front of a room of psychologists. Sorry, man. Screening. Let me say it. Let me be more accurate. Screening, primary care screening, okay? And effective referral pathways and effective brief intervention. These are things that we can do in primary care, and Healthy Minds is working on that. I actually will say that on Thursday, we find out if we get a $9 million grant from TSET to launch the Oklahoma Integrated Care Resource Center, which will expand radically integrated care practices in health systems across Oklahoma and offer resources for primary care physicians who want to do measurement-based care and do screening in their practices. We're very excited. We hope Thursday we get good news on that partnership with OSU. So we passed a couple of bills. One I'll talk about in a minute. Let me go ahead and go to that slide. Senate Bill 254 in 2023 requires insurance companies in Oklahoma to pay full price for an out-of-network provider if that individual on that plan was unable to find within 30 days a behavioral health provider, okay? So let me say it again. If you are not in network with Blue Cross and you have an eligible client who is working with Blue Cross to try to find a provider, unable to find a provider, they go to you. Blue Cross owes you your full price, whatever the heck you charge. That is the law. Yes. Treatment within 30 days. Yep, you can get within the door in 30 days for an outpatient visit. For inpatient, those numbers are a little bit different. I don't remember the exact bill, but I can find it if you're interested. Okay, so that's just one example of the work that Healthy Minds did. We also actually required insurance companies to offer more frequent auditing of their networks and do some more stringent reporting to the state insurance department so that those networks are a little bit more accurate. But we've been working on that. Where we're going with this, our big legislative push next year is requiring insurance carriers to adopt medical necessity practices and medical review practices that are consistent with generally accepted standards of care. So what has happened nationwide when insurers have been sued over parity violations is we have found that they have had contracts with consultants who develop medical review practices that are based on the sole goal, or at least the number one goal, of saving insurance costs, not providing care to individuals. So what we are saying here is Oklahoma will join states like Georgia and Illinois and others that have passed legislation saying insurers must approve and deny care based on generally accepted standards of care, AMA, APA, nationally medical standards that are generally accepted, not proprietary standards. What we are seeing right now is that when you're talking about whether a care is denied or approved, you as a provider are speaking a different language, of course, than the insurer. If the insurer has a contract with a consultant who has developed a set of medical review practices, you don't know what those practices are. You don't know those policies. Those are proprietary. They're probably not telling you, right? There are companies that actually are infamous, insurance companies that are infamous for denying every 12th claim. They've been sued in other states. They deny every 12th claim, and they just hope that somebody appeals. And then a certain number of those are not going to call an appeal because they don't want to deal with the insurance company. These are very real challenges. And I will say, and I feel like I've been very negative against insurance companies here. We've got some good carriers in Oklahoma. They're working with us. They're working with the legislature to try to solve this. They've been collaborative with us. And I don't want to say that they're fighting this at all. In fact, when we've talked to a few of them recently about generally accepted standards of care, they say, yeah, we don't love it, but we're not going to fight it. Like, we understand. So this is something that we're going to work on with the insurance industry as collaboratively as we possibly can, and data-driven as we possibly can. Another thing that we need to do is we need to work with the state healthcare authority and the Department of Mental Health to ensure that intensive levels of services and those things that we would expect of CCBHCs are actually happening and are monitored appropriately so that we know that they're happening. That level of intensity is there. Healthy Minds has been producing, if you go to our website, research on how the state can effectively regulate CCBHCs so that we don't throw the baby out with the bathwater on this model, that we actually do the model right, and that these providers serve appropriately the people that they are designed to serve. So we've been working on that as well. Children, youth, and families. Those of you who work with children, you may have a soapbox around this. Behavioral health historically has applied adult levels of care to children. They're not little adults. The treatment model is different. You all know this. The family needs to be involved. There's different ways that we deal with this. But in Oklahoma and in many states around the country, we still lock parents out of an inpatient room when there's a child, right? There's some things that we need to do and that we need to think about a more family-centric, child-centric treatment model that is the cutting edge of how we would deliver children's services. You've already seen this chart, but the children youth crisis is growing in Oklahoma. Some of what we're doing on this front right now, Healthy Minds has been working for a number of years to ensure that school-based services are actually catching need, referring effectively, providing services effectively, collaborating effectively, so that teachers aren't behavioral health care providers, that we actually have behavioral health care providers in the school appropriately delivering care. Healthy Minds has been working with the legislature on a couple of bills around that. And then we heard a lot about competency restoration for adults. We don't have a competency restoration system for juveniles. We would argue you shouldn't even put them through a competency restoration system, but what happens right now is that if you're deemed incompetent as a juvenile, you're generally just out of luck. We just throw you away. We need a system to handle this, so Healthy Minds is starting to work on that. Workforce, I'll talk a little bit more about this with regards to psychologists in a minute. But this chart here is one of my favorite charts that we show because there's actually a way to visualize the workforce shortages that we have. The dark blue line at the very bottom of each of these categories is the federal government HRSA estimated need per 100,000 for that profession. So we need 27.7 psychiatrists per 100,000 in Oklahoma. We actually have 10.8. The US national supply is 13.8. Okay, for psychologists, we need 35.4 per 100,000. We have 13, and the national average is 28.5. That is actually the largest gap of any profession in the state of Oklahoma. We have the largest gap of psychologists compared to any other profession. Social workers are meeting about 3/4 of the need. We have way more LPCs than we need, according to this data. What's up with that? We've been looking at this for years. LPCs are practicing part-time. They're practicing for telehealth entities that aren't necessarily serving Oklahomans. They're not practicing in a clinical way. This is kind of what's happening with the LPC workforce. Or they've got private practice and those Medicaid and commercial clients actually can't reach them. And so some issues there because you talk to providers who say, wait, this doesn't make sense. I can't find LPCs. You probably can't. They're not going to work for you. So some of what we've done with behavioral health, we want to get the data here right. We worked with Dana and OPA a couple of years ago to pass legislation, at least make sure the legislation was appropriate in terms of using data to ensure that we know where behavioral health professionals are working, who they're serving generally, whether they're serving anybody generally. So that information is starting to come through us through licensure renewals now, and we'll be able to do some really good advanced analytics and target resources to developing pipelines in communities with severe shortages. So we're excited about that. We want to talk about allied professions, paraprofessionals, case managers, peers, which are really important parts of the treatment process along some of that continuum of care. And we want to talk about primary care. So there's a number of things that we've done on primary care. We've allowed them to start billing for certain integrated care models. We've allowed them to start billing for screening. So things we want them to do, we want them to make money, we want them to do these things. Diversion to appropriate care is another thing that we focus on. So if we don't have an appropriate behavioral health system, the jail becomes a behavioral health system, the hospital becomes a behavioral health system. That's what's happened across America. So what we have to do is create an evidence-based crisis continuum and practices that divert and partner with public safety officials to divert people to care over cuffs. And the cost of doing this is a lot better. So this chart is showing you in Oklahoma, if we were to address every behavioral health condition through a traditional emergency response, that is hospitalization, inpatient, or ER, it would cost $815 million a year. If we were to do that through a crisis continuum, that is mental health crisis centers, urgent recovery centers that are sort of those front door emergency stabilization, quick medication, things like that, you're going to save a lot of money. It's going to cost $388 million. And the top figure is conservative because it doesn't even account for public safety costs. We know that 60% of people who are in jails and prisons in Oklahoma have a behavioral health or substance use issue, right? There's some great work happening around this in Edmond, Oklahoma City, and Tulsa. Healthy Minds has partnered with those communities to allow 911 clinicians 24/7 access to behavioral health. To allow clinicians in 911 center, so 911 call takers 24 access to clinicians who can dispatch mobile response teams instead of police. That alone can do a lot because then those mobile response teams are going to have a set of tools that they use that are clinical tools instead of punitive tools. And our law enforcement officers love it because they're seeing less overwhelming 911 calls for mental health issues, which is something they've dealt with for a number of years. Again, CCBHCs do run a lot of these, so we're talking about strengthening those. And we're talking about partnering with substance use providers and partnering with a number of other clinical providers to work with our public safety officials, our jails. For example, we've got to talk about civil commitment. Civil commitment can be an effective tool. It's not the most effective tool, but it can be an effective tool, and it certainly can be a way to divert people from criminal justice commitment. So we can get a judge's order for treatment and things like that when necessary. And we can talk more about that because that's a complicated tightrope. So for psychology, Healthy Minds did a research study of the psychology workforce, and we talked about how we can start to close what is the largest gap between need and supply in any behavioral health profession in the state of Oklahoma. I'll briefly walk through this report. It's available on our website. Oh, and it's outside on the desk. Great, thank you, Dana. So again, these are those data points that I mentioned before. So for psychology, here's what's interesting is that the supply is going up a little bit, but the demand is not ceasing, and we're nowhere near meeting that demand line. We are actually, if you were to look at a chart of the behavioral health professions graduating from Oklahoma higher education, you would see that degrees are going up. We're issuing more degrees, including more psychology degrees, but we're not seeing that translate here quite as much. Why is that? Well, here's one example. This table is showing you the number of psychology internships in regional states. So the colored column here on the left is the percent of adequacy that the psychology workforce has in that state. The red is the less adequacy, blue, more adequacy. And you can see the number of internship slots, the population of the state, and the internship slots per 1 million residents. So here's another way to look at this. There's pretty much a 1-to-1 ratio here of how adequate your workforce is for psychology and how many internship slots you have in the state. Okay, Colorado has the most adequate and the most internship slots, and Oklahoma and Louisiana are down there at the bottom left. So we are graduating people with psychology degrees who are going out of state, and they have to go out of state. And they're probably going to stay and practice out of state, and they're probably going to meet their family there and kind of raise their kids there. All right, so that is a problem. We need internships and we need postdocs. So some of the recommendations that we had, we can go over this more in that report and talk more about it later. But we need additional training opportunities. So there are a number of ways that other states have increased internship slots. We like the Missouri consortium model. There have been states that have appropriated legislative dollars to this. Healthy Minds attempted to do so in 2023, I believe. The legislature chose to appropriate money to growing psychiatry residencies and not psychology, but we'll continue to be working on that. Another point of recommendation is our research found that we need specialized testing domains, and autism was a big deal. So we've got gaps here. We've got to start to talk about. We need varied practice settings. We need psychology. It's great if many of you are in private practice and practicing in your own clinic. That's fantastic. We need psychologists at CCBHCs. We need them at healthcare institutions. We need them in primary care embedded there. We need to find ways to diversify where psychologists practice so that access to psychology grows. We need to utilize psychologists' greater level of education and skill in supervising master's level folks. We've got to talk about financial incentives. So some states, and actually in Oklahoma, allowed this back in 2004 for bonuses for psychologists. There have been a couple of bills. Healthy Minds was behind both of these two bills at the bottom here that talked about funds for recruitment, either bonuses for people who are taking up a new profession and then, or loan repayment or things like that. There are some things that we can do if we want to appropriate money to incentives. And then administrative barriers. We've been working on this for a couple of years, of course. So we talked about removing the Medicaid annual cap for psychological testing. That went up by a little bit recently. We do need to activate some additional codes, and Dan and I have talked about that for a couple of years in terms of psychologists earning money for collaborating with primary care physicians. Let's zoom out a little bit. So how are we on time? Okay, let me go through some of the kind of current events here happening. Okay, so the Department of Mental Health is in a little bit of a budget crisis. This started with then Commissioner Ali Friesen, who discovered that the department had a significant budget shortfall. The legislature then went to the commissioner and said, well, what is your budget shortfall? And she said, I don't know, we can't figure it out. The entire DMH team from the previous administration at the top had previously left, essentially. So there was really no institutional knowledge. The legislature essentially got fed up with that and said, we think that you are incompetent. This was the finding of the interim committee, the House Committee, Select Committee on Behavioral Health that met and interviewed and grilled the leaders of the agency. So the legislature then chose to oust Commissioner Friesen. She was the first public official ousted by the legislature, I think, in almost 100 years. Is that right, Randy? So the new leadership of the department is led by interim commissioner Greg Slavonic. He's a rear admiral, retired. His agency and his administration has continued the work of Commissioner Friesen in looking at their contracts to try to shore up the budget shortfall, because here's the thing, they do have a budget shortfall. It started with federal Medicaid match declining. It was worsened by the Commissioner Friesen and her work to grow the department's budget and personnel costs. They increased their personnel costs by about 50% without knowing necessarily how much money the agency had. This is one of the reasons why the legislature felt like they had to act, right? So now we're cutting services because we added a bunch of state workers and gave them raises. So we're cutting services. So now flash forward to fall 2025, that work is continued under Admiral Slavonic. They've cut about $30 million worth of contracts, 300 contracts worth about $50 million. Many of these contracts they deemed unnecessary. Some of them we would probably agree were unnecessary. Not all of them. Healthy Minds does not agree that all of them were unnecessary. They have also been really taking away a lot of the money that CCBHCs get to serve people who are uncompensated, and to the effect that we've actually had some national consultants come in and work for us who said probably about 1 to 3 years your CCBHCs are going to go away at this rate unless that's taken care of. Department of Mental Health is highly important, as you know, because they regulate, serve, certify, and operate treatment centers largely for people on Medicaid and who are uninsured. So a lot of those uninsured services are what we're talking about when the department is cutting. Currently, a lot of these cuts are affecting Northeast Oklahoma, but some are affecting Central Oklahoma. Gateway is a big example of that in Shawnee. They're an outpatient substance use provider that has already closed several locations. Here in Tulsa, Center for Therapeutic Interventions treats about 8,000 people substance use disorder a year. They've lost about 60% of their budget. Grand Addiction Recovery Center is the largest certified inpatient SUD facility in the state. They announced that they were closing at the end of this year, but then got a supplemental deal to keep them open until June. But if additional funding is not available, we're going to lose 200 substance use beds. here in Tulsa. So there are certainly ramifications here. This is the, apologies for the poor map quality here, but the number of those certified crisis centers and urgent recovery centers that are the backbone of Oklahoma's mental health crisis system, they're run by CCBHCs. They're all over the state. Many of these are starting to close. So Red Rock, North Care are closing some in central Oklahoma. Several providers are looking at closing others down east if we don't get additional funding. So there's some ramifications to this. I'll try to speed through this. We've also seen a dip in federal funding. So the federal government issues competitive grants that support services in Oklahoma. We've seen about $750 million worth of competitive grants from the federal mental health agency alone. There was talk in the presidential administration that we would go back to 2019 levels of federal grants that would result in about a 40% reduction in funding. We have seen, we don't know how much, but we've seen a large dip in the number of notices of funding awards coming to our state. So we're going to see less federal grants there. These are where the federal grants are coming from or going to in mental health. That big one in the middle is the Department of Mental Health, and those are largely statewide. Okay, and then we had HR 1, the One Big Beautiful Bill, as you all know, that had a lot of impacts. Separate from HR 1, we actually just, we're talking about this right now in the news, the subsidies for the Affordable Care Act, insurance subsidies have not been renewed. So that's about 300,000 Oklahomans who would have to have higher premiums to retain insurance. Oklahoma hospitals are estimating nearly $9 billion in losses as a result of this bill. We're seeing we're going to see, this is an interesting experiment. We're applying work requirements to Medicaid. They don't apply if you're getting substance use treatment. That's one of the exemptions. They don't apply if you're volunteering. That's one of the exemptions. But what we've seen is that the Healthcare Authority is not very adept at actually at verifying whether people meet Medicaid criteria. During Medicaid unwinding, we saw a lot of people kicked off the state post-COVID, off the state rolls that shouldn't have been off the state rolls. I think I saw about 30% were kicked off the rolls that should not have been in a postmortem of that. So we're concerned about whether we're going to how we're going to verify work requirements is one thing. A number of other things happening. I know we're short on time. Do I need to stop? I'll stop for questions. Let me zoom here to the. What I'm zooming over are some of the bills that were passed by Healthy Minds in recent years, but I mentioned some of them already. So. Absolutely. And I'll end with this. Thank you, OPA, for your support of all that work. Healthy Minds did an independent study of all that work, whether it's in communities or at the legislature. A consultant came in and found out that we had essentially almost $300 million worth of impact from behavioral health innovations, new policies, people getting care, and $1.4 million, 1.4 million Oklahomans impacted by this work in the last 6 years. So we think it's impactful work. We hope to continue working with OPA and others on this in the next 6 years. But thank you, and I'm happy to take questions. Yep.
First of all, I just want to, if this is on, thank you for everything that you're doing up there. Let me tell you, this guy has done so much for mental health in that capital. He's a person you could go to almost any time. If we went back to the one of the other overheads, it's way back there, so you don't have to go there, but you showed Oklahoma, and Oklahoma at one time was divided into 7 areas. Now it's 12, because you showed the 12 up there. I ran a bill and passed it through the House, went to the Senate, and was killed, I think because he didn't understand. But years ago, a DHS person didn't like a certain person, and so they passed, or not a law, they changed their rules where you could not have one adolescent psychiatric hospital per each of those 12 sections.
The CCBHC catchment areas, is that what you're referring
Yes.
to? Okay.
Mm-hmm. You could only have one. And that was put in there by a DHS worker because they didn't like a certain individual. So I wanted to take that out. And so I passed it through the House, went to the Senate. They killed it because he didn't understand. But right now we have 12 areas in Oklahoma, and you can only have one psychiatric hospital for adolescents in each one of those sections. So it stops anybody putting private in or mental health clinic, et cetera. Is that something we can still think that you guys will support and try to pass that through?
I vaguely remember this bill, and I'll apologize, I don't remember the details of it, but we have been champions, as you know, for provider choice and ensuring that there is competition in these areas. That's partly why Tulsa and Oklahoma counties now have multiple CCBHCs, because we said you can't just leave it to one provider. So we'll talk more about that. Yeah, so integrated care, we're a big fan of multiple models of primary integrated care. We're a fan of the collaborative care model, which features a psychiatrist working with a behavioral health case manager who can be a psychologist or another psychosocial professional. We're also a big fan of primary care, the primary care model. FQHCs are big fans of this model too, that largely features psychologists delivering that care. We're also a fan of, if you just put a psychologist in your primary care, so we're going to improve lives that way. I mean, it almost doesn't have to be a model. So if you're screening and you've got an on-site clinician, that's a good thing. But we're also shooting for one of these evidence-based models like the primary care model and others. Yeah, so the care center that I mentioned, the resource center, that would be funded by TSET, would both deliver technical assistance to a primary care setting, and they have to actually change their workflows around. They have to actually take their people off of the 15-minute appointment kind of situation that they used to bill and put them in a different model of care. So it's a big deal for a primary care or a health system to do it. So this resource center would actually give them upfront funding to do that, provide technical assistance through national partners. And then there would be another layer of services that would be really just convening a lot of health systems and primary care providers around screening, measurement-based care, and just some basic practices that we could do. What we don't want is for primary care physicians to say, oh, this person has a behavioral health condition, let's just refer them blindly out, because that's just, the workforce is not equipped to deal with that.
A couple of things. One, I think you point out, definitely we need more psychologists, more mental health providers. And I think my concern always is not that we don't need more, but to make sure that in the rush to get more warm bodies, that they're still competent to do. Because my experience with 20 years being in here is that I'll get people in my office for therapy or for an assessment, and I'll go through their mental health history, and they've been in therapy 3 or 4 times, and I have sometimes it's like I keep a list of people, okay, never refer to that person. I think we have a glut of bad therapists in Oklahoma. That's probably not nice to say that, but I think that's a problem. We have a glut of poor, and I don't think they're bad people. I think they're poorly trained and they don't know what they don't know. So I think that's one issue that we need to focus on. Quality is as much as quantity. The other thing is, particularly in integrated care, but other places, I think it would be helpful if we had a conversation and made it very clear to policymakers, to our colleagues in medicine, healthcare administrators, what jobs can be sort of interchangeable between a psychiatrist, psychologist, clinical social worker, and which ones need that specific skill set. Because what I've also seen happen many times is a job that was probably meant for a psychologist gets given to an LPC or a LMFT or someone who, again, good people doing their best, but they don't have some of the skills that we have. And, they're probably jobs we shouldn't be doing that they would do, but we're not all interchangeable. So I think we need to have a very clear distinction of what do we do in common that probably any of us could step in and help with, versus which of these roles strategically need to be which specific profession. Because I think that's, again, we experience, any of us who've talked to policymakers, they don't know the difference between the different. I've tried to work with credentialing before, and they're just shocked in a health system how many different licensures and credentials we have to account for if we want to include LPCs, LMFTs, psychologists, psychiatrists, nurse practitioners, substance abuse counselors. It's just amazing. They think it's just shocking to them. So, and they don't know the difference.
Yeah, I couldn't agree more. And that was the root of my comment of, we don't want them to blindly refer out because of the bad therapy that you just mentioned. The research that I've seen nationally is that about 30% of the time, behavioral health outpatient care is evidence-based. 30% of the time, nationally. So it's a problem. And we also see this issue particularly recently with the forensic system and the Department of Mental Health's ability to apply psychology to those evaluations. They're putting masters or below on those evaluations often, which is a concern. Yeah.
So Zach, 2 questions. One, do you see a future where psychologists, either private practice, agency owners, different things like that, might be able to contract directly for funding, either with departmental health or I don't know about this TSET thing, but something like that. Because to Dr. Boyd's point, if a psychologist was supervising some of the other provider types, we might be able to lend our expertise and get a lot bigger bang for the buck to get out to the people with some competent services for, the bachelor's or even peer recovery. But right now, the way it is, we can't contract for any of that funding because of the CCBHCs. And kind of to Randy's point, it just in Muskogee, we tried for years to do a day treatment, adolescent day treatment for a stopgap to all of the inpatient placements. And because we couldn't contract directly, we couldn't get funded. And because we couldn't get funded, we couldn't do the program, which is necessary. And it could have saved the state money in the long run, but it's kind of that wheel that we can't get out of.
Yeah, we've been working.
I was just going to say, and how can psychologists maybe be in positions to provide some of our expertise to some of the very well-meaning providers that just need some support, that maybe we could support 10 and they could see 30 people each, and where I can't see 300 people.
Yeah, I wish I had a good answer for your last question there. We've been working on the state and CCBHCs to employ the federal government allows CCBHCs to subcontract and some of that monthly PPS payment to go to independent providers through a directed care organization model, a DCO. It's been 3 years of us harping on this. I believe now 2 CCBHCs are starting to do this. The state has struggled to develop guidelines and answer CCBHC just logistical questions about how that would work. So several of them want to do that, and they just have turned to DMH and have really not received a lot of help on how to and guidance on how to do that. It's slowly going to start happening. So you're going to see independent practitioners be able to step up to provide some more of that outpatient level of care, in particular for CCBHCs. I think while they focus on the more intensive models, that would be my hope. And that's something that we continue to push, but it's just been slow going. Okay, I think Dan has given us the cutoff. Thank you all. I appreciate your time.
Thank you so much, Zach. Zach has been a good friend to us, and we will continue to work with him and collaborate and work on all the things we've talked about. So we're going to start lunch very quickly. If you guys want to go ahead and line up, go ahead and get your lunch. If you want to take a quick little break, and then very quickly over the course of lunch, we'll move on to our next presentation on our legislative sort of agenda.